Now, the positioning here, and where this is low back, so this is our low back SI joint, ideally crooked pelvis, but watch, everything will be perfect. That initial assessment, I come in, and this is already a pretty good sign. Right? This is not too bad. The pelvis is actually able to kind of rock and rotate. Knowing when it feels normal-ish is probably the most important part, because then when it's off, it really jumps out at you. When you finally meet a person where you move them, they're more like this, like, oh yeah, somebody put some cardboard or some plywood and strapped your ribs to your tailbone. Yeah. Right here, how I can use this kind of rhythmic yeah, oscillation. I got it. Rhythmic oscillation as a transitional application, a way for me to move from one part of the body or one side of the body to the other. Because this is doing something effective. Think about all those little joints at the lumbar spine and the hip joints, how that is causing little pivots and movements in each one of those jointed structures. So doing just rhythmic oscillation as part of the treatment may be something that actually helps cause the effect you're looking for. But you'll never know fully, because usually this is not the only thing we do. But don't discount incorporating little things like this. I'll get there, or I won't. I think my brain is probably just gonna degrade. So forgive me if I stumble. Here's where I can be more precise, just grabbing the sides. I'm looking for the iliac crest, so I'm actually pulling the pelvis. So I can kind of compare how far can I get the pelvis to rotate this way versus the other way. And the whole time I'm palpating the tone of the erector spinae and everything else. And oh, not as much. This is harder for me to pull. So if I'm exaggerating the distortion in my mind, I do this. I'm like, I think they're stuck like that. That would make this harder to get that. Usually to me it's easier to try to mimic the distortion using your own body than trying to just problem solve it mentally. Be like, well, that muscle does internal rotation and this one that. Just kind of make yourself crooked and feel what you had to tighten up to pull that off. Okay. Now, you have your basic routines of coming through and just good general squashes. You see how even with the forearm, those rhythmic oscillations can accomplish a lot. That'll be kind of a way where then I'll sink in, pressure, and then it's just right.
That's good.
Okay. Too much, too little?
Maybe a little too much.
A little too much. So, warm stuff up. That's where the initial applications, keeping them more gentle. I do not want to be sensitizing the body with hurt and pain related, too intense related sensations. I want things to calm down. So, little kind of gentle squish with no further intent really, some assessment, but predominantly I'm just trying to warm up those superficial surface layers before I go any deeper. Now here, pressure.
Good.
Good. And I can do more pressure there. So everything's correlating. And which side did you say was more? The left.
Yeah.
Pressure still good?
Mm-hmm.
Okay. That's where sometimes you gotta say, all right, if that's what's happening, then you just, I have to assume the symptomatic side is the wrong one. Now, maybe that might not always be the case, but when twisted, if I think of this as the short part, so maybe more erector spinae, what have you, but I'm gonna come over to the least symptomatic side. I'm gonna try to work on the least symptomatic side first and then over there. Two things can happen. If I change the tone on one set of muscles, they have their pair over here, so maybe reflexively we get that tone to shift without even doing anything here. And then I get the compare and contrast for the palpation assessment. Tone of these erector spinae versus the tone of those erector spinae, and client's feedback based on where are these tender points, if any. Finding the L5S1, that posterior superior iliac spine part, is tough. You just gotta look for it a ton. It'll get easier as time goes on. I'm gonna put the skeleton right on you. So here we go. I'm feeling along and I'm just trying to find that part of the pelvis, posterior superior iliac spine, and just go medial and just superior to it. And I'm trying to be on with this, that strip of muscle right there. So the erector spinae go all the way down. If this ever becomes too much of a challenge for you, stop, save your time and energy, do it in the sideline. I show this predominantly because the way I'm able to apply force is going to take, and the clothing will act as a good analogy. I'm going to start applying some compression to just get a hold of the tissue and pull it along. I'm going to try to pull it toward me and then up, superior. The idea is to unstick everything from the SI joint. I may not be applying force directly on the joint, but from a connective tissue standpoint, if I can just gather as much tissue that's nearby and pull it up and away, then maybe we get a nice stretch. So I've done everything from just track the spine all the way down until I find the sacrum, and then I search. There we are. There's the PSIS. This is where I start the application with my olecranon, with my elbow. But once I'm there, I'm going to flatten out, pull a little bit toward me, and go up. And that's where the pressure is essential for me to check in with client. So, okay, you tell me the pressure's just right.
Good.
Okay. Now, I could just hold. If I was on skin, then I would have a glide that I could eventually have. And this would only be a couple inches, by the way. Don't try to take this. I'm twisted. This is not the best biomechanics. Don't try to make this stroke go all the way up to the ribs. It only has to cover literally this much. And then change your body and move on to the next spot, okay? So, here, when things are symptomatic, she mentioned there's a little bit of some nerve referral coming down this leg. This is where, yes, the firing pattern stuff is amazing, but having a person lift their leg in this position is a fair amount of effort and can cause some strain here at the SI joint and low back. So it's not something I tend to start with. Right? It's an important thing to eventually introduce, but I am preparing you to do the safest stuff possible. I already have the pillow underneath. I'm gonna do my pressure check-in again.
That's good.
Okay, excellent. As opposed to lifting the leg, why don't we just try the little hula hoops? So I say to the client, I want these motions to be super slow, super small and controlled. You're just gonna roll your whole pelvis around. Think like little hula hoops. And ideally you find a spot that makes right where I'm pushing feel as comfortable as possible. Once you find that spot, you just hold it right there. And she's just doing all these cool little tweaks. And we hold for, you gotta try to be patient. So 10 seconds is the more ideal range of time. I may, just for the sake of getting this captured more quickly, have to reduce that, but you really should have them hold it longer. Shorter duration, more reps. It's not as effective as longer duration, fewer reps. So, okay, slowly let go back to neutral. Now, has that changed? Stayed the same? Gotten worse?
It feels a little bit better.
A little bit better. So ideally, that's what I'm always looking for. Now, this isn't really the symptomatic side. Everything's connected. Anything hiding there? Not as bad?
No.
Okay. Sometimes I might feel something and I just do a quick check. Does that feel like Am I just feeling tight muscle everywhere, or is it actually something profound? So, we're gonna move along. Let's get over to the actual site of orneriness. So now we get to compare and contrast, and I could even say that to them, like, okay, now we're gonna work on this side. Let's see how it compares. So find the spot, pressure. Sometimes this arm is going over to the opposite leg and pulling them toward me. Give me some counter pressure, okay? So, all right, pressure. Okay. Now how does that compare? More sensitive, about the same?
About the same.
Okay. And then little hula hoops, look for a position. Now we could also just continue that. Move the pelvis, do little hula hoops. We don't necessarily have to find a position and hold it. If we do rotations or do multi-plane movement, we're gonna at some point get a contract, relax, antagonist, contract to happen. So, all right, that change at all?
I don't know.
I don't know. And this is the thing. This is where, if I've had a case of aggravating a low back thing, it's in the prone position. Okay? So be careful. How about here? Am I finding anything there? Okay. Now, between the two of those, which one feels like it's maybe a bit more similar to your symptoms?
That one.
This one. So more lateral, which fits. So I kind of knocked out that maybe SI joint, that S1L5 isn't my primary focus. Something more lateral. So I just confirmed that, and I'm just going to go with that assumption to start. Pressure.
Good.
Okay. Let's also do the hula hoops here. And she's braver. The motions are a bit bigger. They're a bit more smooth. So I'm going to go with one. I get feedback related. This feels like you're more on something important. And I get the sense that the movement doesn't feel as vigilant and scared. All right. Now, something to always check on is how are the hips doing in relationship to the low back. So this position of, now I'm holding here, so if I feel the pelvis start to shift, I know we've actually reached the end point of what the hip joint wants to do. So out there. And it's a little hypo in both directions. That's better after a few movements. That's 45 and a little. It's already changing. So now we're going to see some kind of hip rotation manifestation tends to occur with low back issues. So we're going to check here. Aha. A lot more internal rotation than the other side. And that is less internal rotation. That is the most common pattern I tend to see. That with low back, something, especially the symptomatic side, tends to lose internal rotation. So remember that the foot will fake you out. Internal rotation, external rotation. So, my placements here, this is where we're going to talk about the deep lateral hip rotators. The most famous of which is piriformis, because related to sciatic nerve impingement, people get told they have piriformis syndrome. So it's just that hole has to come down through all that. So, common thing. Whether or not it's specifically piriformis tends to not matter too much to me. It's something in the deep lateral hip rotators, okay? And they start, find the greater trochanter, and then go medial, but then you gotta start going inferior too. There's a bunch way lower down than just up here. Piriformis, then you got the other 5. There's 6 in here. Okay. Go here. And I start my application thinking more glute maximus, and if I have a thing here, if you watch the shirt, I'm going to try to apply force that takes all the tissue down and away from the low back. So I get myself oriented so that I nudge the glutes down and away from the low back and the SI joint. And pressure doing good?
Mm-hmm.
Okay. A little bit more, or is that about right?
That's good.
Okay. Now I passively can do the joint movement piece. Or we could include active movement, but I'm going to show the passive piece a little bit here. Where I kind of find that end range and I go, okay. I gauge right where it is. This is where I'm standing, like, all right, in line with my nose right now. That's the position of bind. Does not feel like it wants to go that way. This is the position of ease, the way it feels like it wants to go. Ideally, that correlates with this being more comfortable. Does that feel a bit more comfortable when I take your hip that way?
Yeah.
And so, yay. Position of ease. So this is positional release. Just I passively did it for them instead of having them actively do it. Okay. I've waited. Patience. Patience, virtues. Come back. And I go, oh, it's past my nose. Wow. Take your small victories and run with them. Wait a little bit. Come back, and I want to encourage it just a bit more. Okay, good. A little oscillation to just kind of transition. Square them up a little bit. Now we're going to come in for the deep lateral hip rotators. There's the greater trochanter. So I find that, and then I'm just going to come up over top and track medially. But then once I feel like I'm in about the approximate place, I need to go more on a 45-degree angle into them. Does that make sense? Where I come up and then not down and not right across. I got to be on a 45. So as I move the hip, I can feel that trochanter. So I don't apply a lot of pressure. I do this rhythmic oscillation and I feel for that trochanter, and then I get a sense, where's the top of it? I want to start there so that I do get piriformis. So slow compression, pressure, you tell me when it's just right.
That's good.
Okay. Now, what I tend to prefer here is to actually go into the internal hip rotation. If I go into external, the greater trochanter will roll up into my forearm and it'll feel more ouchy. If I go this way, that bone just rolls right up into me. If I go this way, I actually gap that space. Thus, I am stretching, I'm lengthening those muscles while I'm compressing them. So call it a pin and stretch if we want, but I keep it more mild than pin, crank, stretch. I pin and then rhythmically suggest lengthening. I could call that a technique, right? I suggest lengthening. So compression, pressure, going about right? Okay, and track into internal rotation, and then just little rhythmic oscillations. And then I send all the positive energy I mean, it's small, but I feel a little bit of it let go, and then I work my way down. So forearm's gonna stay here, I come down one bit, and I just went inferior. Forearm application doesn't change much, but that makes sure that I'm getting at least the rest of those deep lateral hip rotators. Here and here. Nice question.
Yeah, I know we're doing this mostly passively, but like, would it ever be more beneficial for her to move it and make it active?
Oh, sure.
Yeah, okay, because usually this one we do passively.
This one I tend to, partly because I feel like I have a good sense of control. But if I said, okay, client, I have you feel that motion, I'm gonna have you push to the inside, rotate your leg one way. Okay, keep coming, hold right there, that's perfect. Okay, slowly let go, now go the other way. Yep, keep coming, as far as feels comfortable and safe. Good, let go. Yes, that is the more therapeutic option. Okay, again, rotate. Good, let go, another way. Doesn't have to be a lot of resistance. Enough resistance to make the muscles really have to, engage. But through range, if the person feels capable of doing it, I'd rather have them apply resistance and go at least 5 or 10 degrees, and then 5 or 10 degrees. So contract, relax, antagonist, contract, plus active movement into the lengthening phase. Sometimes this gets roped into an idea called proprioceptive neuromuscular facilitation. But really, it's compression plus contract, relax, antagonist, contract, but it's concentrically contract, shorten the muscle, and then eccentrically contract, lengthen the muscle.